Good morning to all the students. Today we will be studying about pit and fissure sealants. These are the contents which we are being studied. So what are pit and fissure sealants? As given by Simonson, material that is introduced into the occlusal pits and fissures of caries susceptible teeth, thus forming a micromechanically bonded protective layer cutting access of caries producing bacteria from their source of nutrition. They are PFS. So what are pit and fissures? So pit are small pinpoint depressions located at the junction of the developmental grooves, whereas fissures are the deep cleft between the adjoining cusps. Approximately 90% of the caries in permanent teeth of children occur in the pits and fissures. Similarly, the pits and fissures of primary teeth are also at the risk because of that. So, why fissures are caries susceptible in the newly erupted immature enamel? Because of high organic content, more permeability and caries susceptibility. So, fissure morphology is like that, which makes it more plaque retentive environment, and enamel in the pits and fissures is comparatively thinner, which accelerates demineralization. So what are the morphology of pits and fissures? Nagano in 1961, he has given different types of morphologies like V type, IK type, I type, U type, inverted Y type. So there are different types of pits and fissures. In shallow, wide V and U-shaped fissures, they are self-cleansing, somewhat caries resistant. Deep, narrow I-shaped fissures are quite constricted, resembles bottleneck, narrow slit-like opening is there. They are caries susceptible, and K-shaped fissures are susceptible to caries. So diagnosis is done with the use of the probe, the explorer, with the slight or moderate pressure, moderate to firm pressure. So coming to the history of pit and fissure sealants, Miller in 1905 has given silver nitrate, then in Hayat gave prophylactic odontomy, Bodecker gave fissure eradication, Bunocore introduced acid etching technique, Kyoto and Bunocore then have published first paper on PFS, Clark has given NuvaSeal sealant, and then 3M company has come out with concise white sealant. So how do we classify pit and fissure sealant? So according to the chemical structures of monomer use, they are MMA, TEC-DMA, BPD, bis-gamma, ESP monomer. Based on filler content, they are filled, unfilled. Based on generation, first generation, second generation, third and fourth generation. Based on color, they can be classified as clear, tinted or colored. Based on curing, they are autopolymerizing or light cure. So what are the indications of pit and fissure sealants? The stained pit and fissure with minimum appearance of decalcification or opacification. Deep retentive pit and fissures which might cause wedging or catching of an explorer. No radiographic or clinical evidence of interproximal caries and possibility of adequate isolation from salivary contamination. Where we should not use PFS are well coalesced self-cleansing pit and fissures, radiographic or no clinical evidence of interproximal caries are there, tooth are partially erupted, life expectancy of the tooth is limited, and lack of preventive practices. So, of sealant application depends upon age. Like among 3 to 4 years of age, primary molar sealant application should be done. In 6 to 7 years of age for first permanent molar, and 11 to 13 years of age the second permanent molar erupts, so we should do PFS. Based on clinical judgment, we should see age, oral hygiene, familial and individual history, fluoride environment and history, dietary habits, tooth type and morphology. Based on caries risk, we can categorize into 3 groups, like caries free patient with no risk or zero decay, Group 2 patient judged to be moderate risk to decay, and group 3 are at high risk of decay. So what are the steps of sealant application? First, assemble armamentarium and check for the correct patient position. Then isolation of the tooth should be done, which is followed by tooth preparation, which can be done using rotary prophyjet, pumice, water slurry, etc. Then acid etching. So Silverstone in 1975 has given 3 basic patterns of acid etching, which are type 1, type 2 and type 3. Then rinsing and etching on the tooth, it is done. Then we have to apply the intermediate bonding agent. Some studies says that we should apply the bonding agent, and some say though it is not important. Then application of pit and fissure sealant is done. And care should be taken to prevent the incorporation of air bubble. Then curing is done with the curing light. Then after which evaluation of occlusion is done, whether no high points or anything like that is there. Then finally it comes to recall and re-evaluation of the patient after 3 months, 6 months and so on. So as to conclude, we can say that determining the optimal form of management for an early decay lesion is the key for diagnosis and prevention. Thank you.